can see that there's a lot of passion for some of these topics. We're going to, the next talk, we're going to switch to trying to talk about some of adjustments or differences when we apply these techniques in pediatric population. And Dr. Gretchen Purcell Jackson is going to present next.
Thank you. I'd like to thank Leanne and Pascal for giving me just a few minutes to talk to you about some of the special considerations of using energy devices in pediatric patients. I have nothing to disclose. So I am a pediatric surgeon, and I wouldn't be a pediatric practitioner giving a talk about children without reminding you that children are not small adults. And even though pictured here, my 7-year-old and my 7-month-old and I all might look quite similar in medical garb, we have unique characteristics that must be considered when you're using energy devices. And many of you in the audience probably don't operate on children, or maybe you just operate on adolescents that are a little bit more like adults. But I think children are a framework of thinking about other patients that may have altered body composition, such as a cachectic elderly patient, or a very edematous patient, or someone with multiple amputations or implants. So I encourage you to think about patients as individuals when you're operating on them and using your energy devices. So I just have a few points to make. First of all, there are some anatomic and physiologic considerations. Compared with adults, infants and children have less total surface area, which means less room for all of your monitoring devices, dispersive electrodes in your operative site. They do have a greater total body surface area to volume ratio, but less total surface area. What this means for you is that areas of high resistance tissues are in close proximity to tissues of low resistance, and thus the path for current flow may be a lot less predictable than it is in adults. And because of the small size of these patients, injury can be really catastrophic. Second, infants and children have a greater total body water content, especially in newborn, preterm, and small for gestational age infants. So you all know that current flow is going to be greatest in tissues of high water content, and children, especially newborns, have significantly more total body water, making the tissues low resistance and good conductors of current. And if you're thinking about doing ablations in children with things like hepatoblastomas, or infants, hepatoblastomas, their tissues are going to have higher water content and they will more highly concentrate energy. So as you know, adults were about 60% water. Neonates are born with excess total body water. It's mostly extracellular fluid, and they lose a lot of it in the first week of life. But still, most newborns are going to be about 75% water. And if you're operating on a premature infant, they can be up to 90% total body water. And that's just something to think about. Finally, infants and children are going to have smaller anatomic structures requiring smaller instruments, and all of those can concentrate current in critical areas. Now, I actually signed up to give this talk because I wanted to answer one question for myself. Where do I set those electrosurgery settings in children by kilogram? That's one thing I've never seen written down in any pediatric surgical literature, and I wanted to figure that out, so I said, it's great. This is an opportunity for me to go out and summarize that literature and the science behind it, and I went out and looked for it, and it's just not there. What I have learned is that the maximal settings recommended for electrosurgery generators are going to vary by device manufacturer, but in general, we're going to use lower settings in infants and especially our newborns and children than we use in adults. And the settings are going to vary by device, and calibration may be necessary. And I'll give you an example. This is a sticker they provide for us with our ValleyLab neonatal return electrodes. These are intended for use in preterm infants that weigh anywhere from 0.45 or 0.4 kilos to 2.7 kilos. So that's like 1 to 5 pounds. And their instructions say, prior to initial pad use, the electrosurgery generator should be calibrated by a qualified biomedical engineer or technician to determine the control setting that represents a maximum current level. So they should be calibrated individually, and one device from room to room may be different from each other to provide a maximal current of 300 milliamps. And that's what's recommended for this particular electrodes for children in this side. Now, again, I have never seen in any of our operating rooms these stickers on there saying the maximal settings, but it is something that really should be considered when you're taking care of these very, very small infants. Another comment that I will make is that one of the things I find since I have become a pediatric surgeon and operate mostly on children is those settings that may be astounding you, the low electrosurgery settings, your cut your coag settings that people are using or talking about using here in these talks. I use less than that every single day, and I operate on 350-pound adolescents too. So we've learned in pediatric surgery, it's dangerous to use those high settings. We use the lower settings, and you can often do it safely. All right, a few words about dispersive electrodes in children. They are available in weight-based sizes for infants and children, as I've talked about. The lower limit is about 400 grams or about 1 pound, and that's about the limit of a child that's going to actually tolerate an operation in which you would use any type of energy source. Adult dispersive electrodes are used when a patient's weight exceeds about 30 pounds or 13.6 kilos. The size of patients, especially infants or young children, and the proximity of structures makes your electrode placement challenging. And I will remind you, if any of you do have the occasion in a rural center or in an emergency setting to operate on a neonate, that their skin is extremely fragile, but this is the same as true for elderly women also. Beware of adhesives on the electrodes and consider bipolar devices whenever possible. Now, many of the guidelines for placing electrodes are going to be the same as adults, but they warrant repeating for children because the placement is more challenging, again, because of the size. Now, as you've probably learned today, the ideal site for your dispersive electrodes is going to be well vascularized, convex in shape, close in proximity to the surgical site, but not near scar tissue, bony prominences, or excessive adipose tissue. So for the smallest patients, the best sites are going to be on the back. For a neonate, in general, you'll place it between the scapula and the sacrum on the back. But all of these sites on the back are at risk of pulling from fluids, either from your skin prep, the drainage from your operative sites, or irrigation during the operative procedures. And in very, very small babies, almost any site is going to be at risk. As for any person, you do not want to cut or modify that dispersive electrode. If you are using you can use the back of the torso. You can sometimes use a thigh in a big chunky infant, but if you do that, you have to make sure that when you wrap the electrode around the thigh that you don't overlap the edges. And one of the big challenges can be in putting on these electrodes is making sure you don't contact any other patient leads or cables, again, because there just is not much room. And finally, you really need in children to be sure, in everybody, but especially in children, to protect that dispersive electrode from fluids. So in all of my patients, I will put waterproof drapes on the side and prep right down onto them. And this not only in small children that have a large body surface area to volume, it helps keep them warm if you have a warming device underneath, and it protects that dispersive electrode if it's on the back. Just one note, dispersive electrodes used in radiofrequency ablation do have those longer periods and high concentration of heat, and that increase in heat in the dispersive electrode can cause burns. And so some of the recommendations, if these are used in children in solid organ surgery, is if you have a heater under the patient, which you often do, is to consider keeping that heater off until your ablation is done to help prevent burns at that dispersive electrode. Finally, if we move our spectrum of patients to considering our very youngest and smallest of patients with the fetus as a patient, electrosurgery in pregnancy, there is no evidence that any electrosurgery in a pregnant mother poses risk to a fetus at any stage of development. The amniotic fluid is very electrolyte rich, and it protects the fetus from concentration of current, and the output of the electrosurgical generators is above that level that stimulates muscle contraction both for the adult patient and for the fetus. And the only big risk there is if the fetus is directly touched by an active electrode, such as during an emergency C-section delivery. All right, that's just a couple points for children. I can take some questions at the end of the presentation.
Thank you very much.